I'm Dr. Fakir Awari, and this is sexually transmitted infections in adults. Many infections are associated with sexual transmission. Now, these were traditionally termed sexually transmitted diseases or STDs, and currently they are termed sexually transmitted infections or STIs. Now, by calling them infections rather than diseases, we can reduce the stigma associated with STDs and place these infections within the context of a larger sexual health framework. And not all of these STIs will manifest as an actual disease. Now, since 2000, rates of STIs have continued to rise. For example, chlamydia cases have doubled during that time, gonorrhea has increased 40%, and primary and secondary syphilis cases have soared fivefold. And nearly half of STIs are acquired by teens and young adults between age of 15 to 24 years old. The first STI that we'll discuss belongs to the human herpes viruses family. So these are the herpes viruses that contain double-stranded DNA. They're surrounded by a nucleocapsid, which is wrapped inside a tegumen consisting of several viral and cellular proteins, which are in turn surrounded by an envelope which has viral glycoproteins. Now, human herpes viruses are divided to three subfamilies, so the alpha, beta, and gamma. Within the alpha family, we have herpes simplex virus 1 and 2, which, essentially there are 8 of these human herpes viruses that infect humans. So these are dubbed HHV 1, 2, 3, 4, 5, 6, 7, and 8. So the first one, HHV1, is specifically herpes simplex virus 1, and along with HSV1 and HSV2, these are viruses that essentially lead to latency. So once somebody is infected, they will reside on sensory and cranial nerve ganglia, and they will have a period of latency, and they will periodically get reactivated. And the third member of the alpha family is a varicella zoster virus. So, sometimes you will hear the term herpes zoster infection. So it's important to distinguish that from the HSV-based herpes infections. Now, when you look at the seroprevalence among adults in the US, you can see that about more than half of people in the US are actually infected with HSV1, which in general is considered the less severe of the two. And this doesn't necessarily mean that it's is a sexual or genital infection, because HSV1 can also reside outside of the genital area. Whereas, far fewer people, so about up to a quarter of the US adults have HSV2. Now, HSV2 is more likely to cause genital herpes, but regardless, both of these can, either cause infection in the face, orofacial area, or in the genital area. And once, they are there, they will have latency. Other herpes viruses that are clinically important include cytomegalovirus or CMV, which belongs to the beta, and EBV, which belongs to the gamma. However, these are not necessarily sexually transmitted infections, but they do have a role in immunocompromised patients. For this topic, we will focus on genital herpes that's caused by herpes simplex virus. Now, other infections that we will talk about in this topic that are non-viral are chlamydia, gonorrhea, and syphilis. Chlamydia specifically is caused by a typical bacterium called Chlamydia trachomatis. This is an obligate intracellular bacterium, so essentially has to go inside the cells of the host in order to replicate, which, if you think about it, that makes it difficult to culture in the lab, because they have to be inside the cell, so you cannot just grow them on a plate. And there are a lot of similarities between chlamydia and gonorrhea as far as manifestation. Now, essentially, they infect the epithelium cells, and that could be, in the eye, in the genital urinary tract, or in the rectal area. But essentially, they attack the epithelium. So gonorrhea, in comparison, is caused by Neisseria gonorrhoeae, which is a gram-negative cocci. And similar, a lot of similarities between these two as far as manifestations, because they do infect the epithelium cell, but they are vastly different organisms, and treatments are different, more or less. And gonorrhea in general is considered more severe, and is more likely to cause disseminated gonococcal infection. And disseminated essentially means that everywhere in the body. And resistance is also an issue with gonorrhea, which we'll discuss briefly. Syphilis, which is caused by Treponema pallidum, which is a gram-negative spirochete. So essentially, this kind of looks like a spring, so to speak, the shape of it. And syphilis is a very severe infection in the sense that but first of all, it has a multi-stage infection. So it goes from very mild infection to essentially life-threatening infection over a period of time. So it essentially disseminates early during the course of infection and invades the central nervous system. This can happen at any time during the course of the infection. Now, when we look at resistant patterns, in regards to the report from CDC that was published in 2019, you can see that the drug-resistant Neisseria gonorrhea is actually an urgent threat level. And to put it in perspective, there are only 5 organisms that get the urgent threat level from CDC. That includes carbapenem-resistant Acinetobacter, Candida auris, Clostridioides difficile, carbapenem-resistant Enterobacterales, and drug-resistant Neisseria gonorrhoeae. So this is, urgent because, when you get this type of drug resistant, we don't have a lot of treatment options. And you can see on this small chart down here that as time goes on, the rate of resistance continues to go up to the level that, over a period of time, we have been essentially losing the treatments that we had as an option. Here are some reliable resources. We are primarily going to use the CDC guidelines, which can be accessed from their website. In 2021, the CDC and Department of Health and Human Services jointly released the guidelines for sexually transmitted infections. This guideline essentially includes every sexually transmitted infections out there, including chlamydia, gonorrhea, syphilis, and herpes, which we will discuss in this lecture. There are also CDC guidelines that were released in 2024 for specifically syphilis testing. Now, I will say that the 2021 has that guideline does include information for diagnosis as well as treatment and monitoring. In 2024, it's just the testing part of syphilis that was updated. In 2024, also, we had the CDC guidelines for the use of Doxycycline, specifically for post-exposure prophylaxis of bacterial sexually transmitted infections. And this is primarily focusing on prevention of chlamydia, gonorrhea, and syphilis. Now, the first learning objective is describe the pharmacokinetics and pharmacodynamic properties of anti-infective agents used for the treatment of genital herpes, gonorrhea, chlamydia, and syphilis. So when it comes to antiviral agents for the management of herpes viruses, the 3 most important ones include acyclovir, valacyclovir, and famciclovir. And we also have some topical options that, they're not necessarily, used for genital herpes, but, when you consider, for example, orofacial, for example, Abreva is something that's available over the counter when people have facial manifestations of HSV, and those are topical, so they're listed here. But I want to focus on the 3 that are used systemically for management of patients with genital herpes. So acyclovir, which these are essentially analogs of nucleosides. So Acyclovir is a acyclic guanine analog, and because it looks like guanine, it essentially inhibits viral DNA synthesis. So herpes viruses are DNA viruses. And acyclovir is available as IV, as PO, and as topical. Now it's important that this is pretty much the IV drug of, in case of severe infections, this is the IV drug to go to. But in general, oral options are the mainstay of treatment. Now, the problem with acyclovir is twofold. One is that, the oral bioavailability is very low, so it's about 10 to 30%, and that's why we have valacyclovir. So essentially this is a valine ester of the acyclovir, and that valine essentially improves bioavailability, so it actually increases it up not to 100%, but essentially up to 70% bioavailability. So that essentially improves that. But other than that, the two drugs are pretty similar as far as adverse effects, and of course valacyclovir is not available as IV. Now when you look at the adverse effects, essentially GI effects, so nausea, diarrhea, but also rash, headache, and rarely neurotoxicity. So and this would be in the case of because these are renally clear. So if somebody has renal dysfunction, if they're not renally adjusted, or just in case of overdose, patients are likely to have neurotoxicity, and this neurotoxicity could include seizures. So it's typically confusion, hallucination, but could include seizures. And with the IV formulation of acyclovir specifically, it's also a nephrotoxic agent. So because with the IV we'll have high doses. And I emphasize IV because, if you think about it, the PO version is only about 10 to 30% absorbed, so you're less likely to get these severe rare adverse effects. But with the IV, which you have 100% availability, you're going to get high doses, and so it's one of the nephrotoxic agents. So specifically it can form crystallines, so it can cause obstruction, but also it can cause interstitial nephritis. So that's one of the types of AKI, and so that's something that you don't see with valacyclovir. And then pharmacology also is a prodrug of penicillin. So penicillin is only available as topical, so I'm not really going to talk about it, but essentially pharmacology is a prodrug of penicillin that improves bioavailability, but mechanism of action is the same. So essentially all of these four drugs are analogs of guanine, which inhibits viral DNA synthesis. And here's how it works. So essentially for DNA synthesis, you need nucleic acids. So when you have your four nucleic acids, right? So you have thymine, adenine, cytosine, and guanine, and those are what's naturally supposed to be there in DNA. So they will make the right bonds, and as DNA polymers is making DNA, it will make DNA. Now when you have a compound that looks like guanine, you essentially the polymerase will incorporate acyclovir into the chain, but because this looks different, it's not going to be able to make the appropriate bonds that's required for the DNA. And essentially what happens is that the process of DNA synthesis will be terminated. So that's how these agents will interrupt DNA synthesis. Now, one thing that's important to consider is that before they can actually be incorporated into the DNA, they actually need to be converted to the active form. So they do depend on the thymidine kinase enzyme that comes with the virus. So herpes virus has this enzyme. So essentially acyclovir needs to be phosphorylated by this enzyme, and that's how you get so normally nucleoside will be phosphorylated into monophosphate, and it will continue until the final step where it is incorporated into DNA. So the same is true. So acyclovir and famciclovir and valacyclovir will need to be phosphorylated, and that's something that could happen. So if there are mutations in this enzyme, it acyclovir will not work. But pretty much for herpes viruses, resistant to acyclovir has been pretty rare. And just to show you the life cycle of herpes viruses, these are DNA viruses. So once they attach to the target epithelium cell, they will go inside, and then because they're DNA viruses, they actually need to go inside the nucleus in order to replicate. So they will have to go inside, and then they will replicate inside the nucleus, and then it will come outside and will have its other protein products, and will assemble into a virion, and then will release and infect the next cell. Now, some of the antibiotics used for management of bacterial and STIs include aminoglycosides, which we know bind to the 30S subunits of ribosome, and they inhibit protein synthesis. Of course, aminoglycosides associated with nephrotoxicity and ototoxicity. We'll also use tetracycline. Specifically, doxycycline has a big role for some of these infections, which we know they bind to 30S subunits, similar to aminoglycosides, to inhibit protein synthesis. For tetracyclines, they can cause photosensitivity. And deposition in bone and teeth, there's a question mark here because that was seen with the tetracycline itself, but some of the other agents in this class don't necessarily cause this. So doxycycline is, that's not really a concern with doxycycline. Macrolide, specifically azithromycin, has been used for some of the STIs. So the macrolides are bind to 50S subunit, and they inhibit protein synthesis. And of course, with macrolides, QTC prolongation is a concern. The same with fluoroquinolones. QTC prolongation is a concern, along with a bunch of other things, among which is tendinitis, neurotoxicity, and not to forget about all the black box warnings for fluoroquinolones. And fluoroquinolones work differently in that they bind to topoisomerase 2, which is DNA gyrase, and essentially prevent replication of DNA. And last but not least, we have beta lactams. So penicillins, especially for syphilis, penicillin has a big role. And of course, for for example, cephalosporins are also used for some of these. So ceftriaxone, cefixime. So these are essentially, the mechanism of action is the same. They bind to penicillin binding proteins. Now, there are different types of penicillin binding proteins. So depending on which one beta lactams bind to, that's how you get different spectrum of activity for different beta lactams. And in general, they are pretty well tolerated. You do get GI upset and essentially hypersensitivity or rash. And in high doses, you can get seizure, and also drug fever is a concern in general, but very rare. Now let's take a closer look at doxycycline. So as I mentioned, tetracycline binds to the 30S subunit and prevents protein synthesis. The adverse effects include photosensitivity, and when you look at the GI effects of doxycycline specifically, it can lead to esophageal erosion and ulceration. While tetracyclines in general can cause hepatotoxicity, doxycycline is probably not associated with hepatotoxicity, so it's in general pretty well tolerated in regards to hepatotoxicity. So here are some patient counseling points. So patients should take oral formulations with a full glass of water while standing to avoid esophageal erosion and ulceration. For drug interactions, it's important to separate the doxycycline dose by at least 2 hours from dairy products, antacids, and supplements that contain calcium, iron, magnesium, or sodium bicarb. Essentially, cations can bind to doxycycline and prevent its absorption. And because of photosensitivity, it's important to tell the patients to limit sun exposure, use sunscreens when they go under the sun, and avoid tanning beds. Now, in general, there are 2 formulations of doxycycline. So doxycycline hyclate, and so there are some brand names that have this formulation. these have more GI side effects than monohydrate. So doxycycline monohydrate is the other formulation. So hyclate has more side effects, and there is a delayed release formulation that actually can lower the frequency of these side effects. And when you look at monohydrate is less acidic and gentler on the stomach. And more importantly, doxycycline monohydrate is the cheaper option. So therefore, you're probably more likely to see doxycycline monohydrate used in practice. Now let's take a look at tetracycline allergy. Even though tetracyclines as a class have been on the market since 1940s, tetracycline hypersensitivity reactions have rarely been described in the literature. Minocycline carries the greatest risk of serious non-IgE mediated reactions that are often dermatologic and pulmonary in nature. Tetracycline itself has been associated with less severe dermatologic reactions, such as fixed drug reaction, whereas doxycycline, which is what we're interested in this topic for treatment of STIs, doxycycline may carry the best overall safety profile regarding allergic reaction potential. And when it comes to tetracycline cross-reactivity, there's really very limited data, so dermatologic manifestations can be variable. Let's take a look at different formulations of penicillin. Penicillin G Benzathine, which is available as a brand name Penicillin LA, or long-acting. This is an intramuscular injection. It is a repository penicillin that provides tissue depots from which the drug is absorbed over days. So even though it may be, for many indications, a single injection, it will actually be acting over several days. And this is very important because we will be giving a very large dose, typically over 1 million units that you will see on another slides. But in particular, this is something that you do not want to inject intravenously. In fact, there is a black box warning against the use of it as IV because it has been associated with cardiorespiratory arrest and death. Now there is another formulation, Penicillin CR, which is a combination of two different formulations. So penicillin G benzathine is half of it, the other half is penicillin G procaine. Penicillin G procaine is short-acting, the other half is long-acting, and it is intramuscular. Of note, this product should not be used for syphilis. So, these are not interchangeable. And because of the benzathine component, it also has the same black box warning. It should not be used as IV. And penicillin G procaine itself, which is short-acting, was available on the market, but the manufacturer discontinued it in 2023. And this one, although it was used as treatment of syphilis, it's short-acting, so it was typically dosed over a period of 10 to 14 days, depending on the indication. However, it's no longer available on the market. And then we have aqueous crystalline penicillin G potassium, which is used for IV formulation. So this is for IV injection. And typically, because this is short-acting, especially for the use in patients with neurosyphilis, this will be used as continuous infusion. And note that these two products did not have the black box warning. And in the last couple of years, there's been intermittent shortages of penicillins. So currently, Pfizer makes Penicillin products, and from the FDA's website, you can see that there are limited availability of these. So because of that, and because of important role of penicillin in treatment of syphilis, you will see that the FDA currently does allow other products that are not FDA approved to be imported from other countries for use in the US. And I will not discuss those because they're not FDA approved.